classify them into two categories. One is about preoperative optimization of the RV. In particular, what happens with pulmonary hypertension, or do you use any pulmonary vasodilators before the operation? So probably that's the first, and lots of technical and detailed questions about your preferred inotropes. I know the one for milrinone, as you frequently debate me with the kilrinone answer, but yes.
Yeah, these are very interesting questions and still very difficult to answer. So concerning the preoperative optimization of RV function, there are some centers using, for example, a 24 hours treatment course with levosimendan in these patients. There are also some believers in kilrinone, like Nandor, for example. For the sake of time, I didn't show the data, but there are some interesting analyses by the Intermex registry finally supporting me in my disbelief in milrinone, showing that the preoperative use of milrinone in these patients was associated with a higher mortality in patients receiving an LVAD. And if you listened carefully to my presentation, then you might know also the reason for this, because with at least an inappropriate use of vasodilators, you can have serious problems afterwards due to left-forward septal shifting, and also, in my opinion, the Vasoplegia syndrome to which Eric referred is frequently caused by the deliberate use of vasodilators, of systemic vasodilators in these patients. So I'm very, very careful in using them. Concerning the right use of inotropes, concerning again the right ventricular function preoperatively, well, it's very difficult, and it remains a mysterium a little bit, because there's still no very well behaving predictor index clearly allowing to identify patients that will develop a right ventricular failure after LVAD implantation. A lot of indices have been described. They mostly work very well in one institution, but in other institutions not so well. So you might agree, all of us might agree that this is frequently more or less a gut feeling of the team, whether the right ventricle will fail afterwards or not. With the tricuspid valve reconstruction in these patients, this also remains a debate for years, and there are no conclusive answers to these problems. So, but yeah, again, I could talk about this more than an hour, I think.
Okay, we don't have an hour, but probably we will answer the specifics regarding dobutamine and epinephrine after. But maybe just one sentence about the threshold of inotropes and whether your decision of implanting mechanical support will depend on a threshold.
Well, at least in our institution, hardly any patient is able to leave the room without norepinephrine. So I think this is our standard vasopressor plus inotrope. And then it all depends on echo and on the Swan-Ganz measurements, whether we start an inotrope or not. But frequently in these patients, I even like to use epinephrine or adrenaline. But I cannot describe an objective cutoff. So it's always a little bit of gut feeling experience when to start these drugs. And I mean, for me, then a threshold where I really think, or where I try to convince the surgeon to go for mechanical circulatory, support in these patients is once I'm higher than, let's say, 0.2 to 0.3 micrograms per kilo per minute adrenaline, and higher than 0.1 to 0.2 adrenaline. And if I do not see a clear improvement with these high doses of catecholamines, then we start the discussion whether or not to place a mechanical circulatory support. Plus, in these patients, my first, if the right ventricle fails in these patients, then my first treatment option is for sure selective pulmonary vasodilation. That means inhaled nitric oxide or inhaled prostacyclins, whatever you prefer. But if this multimodal approach fails, like I showed on my last slide with the algorithm, then you should clearly think of the implantation of an RVAD.
Yes. Moving on to the Vasoplegia lecture, Eric, there are a few questions which I know will require longer answers. But maybe one that can be answered relatively quicker is the issue of hypothyroidism and the potential role of IV thyroxine in patients. Unmute, please.
Thank you for this important question. Well, the thyroxine is a little bit controversial. There are some papers in which higher thyroxine levels are related to decreased systemic vascular resistances. On the other hand, it seems that decreases in thyroxine has an effect on endothelial dysfunction, and endothelial dysfunction causes an increase in nitric oxide release, and therefore causes decrease in increase in vasoplegia incidence. So it's a bit difficult, and I think that the effect of thyroxine in this issue is not fully understood, and I think that more research is needed. And well, if I look to our own research in patients who were scheduled for left ventricular assist device implantation, thyroxine levels or the use of thyroxine medication was not an important predictor of vasoplegia.
Yes, thank you very much. Dr. Mondino, I would be quite frightened to see these patients if I was a general anesthetist without much expertise in the LVADs. So quite rightly, some of the questions relate about performing like thoracic anesthesia. Could these patients be candidates for one lung ventilation? And also about positioning during non-cardiac surgery, prone positions, lateral decubitus, and so on.
Yeah. So the questions, I think, well, positioning it's a bit challenging. You need to be careful positioning this patient for not only for the position of a patient itself, but also be careful not to pull the cable, the drive line, which it can happen and it can create problems. And it's reported that in prone position, sometimes you can have obstruction of the outflow cannula, even though rare. And about one lung ventilation is doable. We do perform lobectomy or pneumectomy on patients on the LVAD. Of course, it depends on the condition of the patient itself, because one lung ventilation will have some effect on the afterload and the function of the right ventricle. So like in any one lung ventilation, you should try to achieve, the best ventilation, but it's doable. But definitely, I think in this case of major surgery, in my opinion, should be a cardiac anesthesiologist that know what is the physiology of the LVAD to perform the anesthesia, or at least two of them. And I think an echo monitoring in this patient, it's important to evaluate the stability during the surgery.
Okay, so I apologize. We are running out of time, I believe. The last question probably could go either to Michele or Chris about a flow chart for the emergency outpatient situations to emergency rooms, and that the anesthetist should be comfortable. So that's part of a bigger question. How do you really train the public or staff in a general hospital? Chris?
Shall I take this?
Yes.
Well, You were probably surprised when I presented data on outpatient management, because you'd think, well, actually, this should be directed at the intensive care and the operating theatre. But actually, we would expect there to be an inherently higher level of expertise, certainly in the VAD centre. But yes, it's of course very important, because we have a throughput of patients, and a throughput of devices, and a throughput of staff. So this needs to be recurrent training, and it needs to be specific to those devices which are in use. I think in general terms, the principles are similar to what I described before. Obviously, it's different when you have an anesthetized patient, but the underlying principles of keeping the device running are very important, and understanding why it needs to be kept running, understanding the variations in the vital sign monitoring, and just the fact that, you know, this is a multidisciplinary team approach that involves many people, not least the VAD nurses and the other cardiologists as well. And we mustn't forget their contribution in the safety of these patients.
Thank you very much, Chris. I promise that we will answer all the other questions, and that will be available on the website. Now, Eric and I, as always, we are fighting for the take-home message. I think I won with that one. Going back to my landscape analogy, that we visited 3 different landscapes: the upper cardiac operating room and intensive care, the non-cardiac anesthetic room and operating room, and also public places for resuscitation. I think it's obvious that we have learned a lot during the last 2 decades, achieved a lot, achieved the impossible, that LVAD is not needed, but there is much more to do. We need to improve our clinical expertise locally. We have to improve our collaborations for exchanging ideas. We have to unite our different approaches and develop some consensus for the debated areas. And we have to unite and collaborate on major research, clinical, physiological, and molecular understanding. And I think the EACTA is a perfect platform, the Transplant and VAD Committee, in association with all the others, and the Scientific Committee for Europe, and also your friendly collaborators in other parts of the world. So that's my take-home message, and now I hand it back to Eric and Fabio to close.
Thank you, Nandi, for this excellent summary. Dear colleagues, I want to thank you for your attendance. But before I give the word to Fabio, I want to tell you that certificates will be sent after you completing the evaluation form. Don't forget to put your email address on this form in order that you can receive the certificates. And furthermore, I want to thank all the speakers. Well done. I'm very happy with this. I want to thank the multi-learning for their excellent assistance. And finally, I want to thank the sponsor, ABIMED, for their unrestricted grant. Now I want to hand over to Fabio for the closing of this for this webinar. Fabio, the floor is yours.
Hello, everybody. I hope you can hear me. Thanks for your encouraging signs, Nandi. It is really a pleasure for me to close this this session, this webinar. I am always extremely happy to see the very high quality of our webinars. Today we had really extremely interesting presentations. All the speakers were so clear in their presentations, and the content of their presentation was so important to us. So it is always a pleasure to see that our educational program is providing our community and our friends in the scientific in the cardiothoracic scientific field, very interesting and very important information for our clinical practice. I really wish to thank the chair, the moderators, the speakers. I also wish to thank for their valuable technical assistance, Multi-Learning and AIM, whose support is always very important for these webinars. And of course, our educational committee and the chair, Mohamed El Taan, who is really a very strong engine of all these activities. As you know, this webinar received an unrestricted grant from Biomed, and I'm grateful for this. And before saying goodbye, I would like to remind everybody that our next webinar will be in December, on December 14. It will be from the program directors of the EACTA Fellowship programs. It will be the EACTA Fellowship Program, More Than an Educational Campus. This is the title. It will be another interesting opportunity for us to hear about the fellowship program that EACTA is running since quite many years. So thank you very much again for joining this webinar today, and I hope to see you all again on our next webinar. Thank you so much, and stay healthy and stay safe. Bye-bye.